Thank you, sir. So, I'll be speaking about the results of the novel CM-T-Flex scleral fixated lens in comparison with the standard SFIOL and iris claw lens. It's no coincidence that just a couple of papers ago, we were seeing what the preferences of surgeons were in case of absent posterior capsular support. So, I have no financial disclosures, whereas my friend Dr. Nivian is the innovator and the patent holder. Right, a little background about the subject. As we were just seeing, in case there is capsular compromise, the age-old options have been to use a scleral fixated IOL or an iris claw lens. Now, each of them have their own advantages and disadvantages. In doing an SFIOL, you place the lens in a more anatomically correct position, and you don't have pupillary disturbance. Whereas on the flip side, it's a little more challenging surgery. It takes time. In iris claw lenses, the surgery itself is pretty simple, but you're anchoring the lens to an important structure like the iris, so you have the chance of distorting the pupil, having glare, producing some inflammation. Well, the CM-T-Flex lens was designed to combine both the SFIOL and the iris claw, to retain the advantages of both while eliminating the disadvantages. The advantages being that it's a simple lens to fix, and the disadvantages of anchoring it to the pupil are eliminated. We still anchor the lens to the sclera. Now, the design of this lens, the method of fixing it, everything has been published in standard journals. The videos have received a lot of acclaim in conferences. People have come up to us and said it's all very good, but actually how does it compare in real life to SFIOL and iris claw? Well, the aim of this particular study is to address that pressing question. We wanted to assess the visual and refractive outcomes of the CM-T-Flex lens and compare it with the standards. We also wanted to look at, more importantly, we also wanted to look at the undesirable effects. This question keeps coming up often. So how was it done? It was done in 2 tertiary eye care hospitals in Tamil Nadu. It was a non-randomized study for obvious reasons, because randomizing in case of surgical aphakia becomes difficult because some cases are managed then and there in the OT. So we had strict criteria. We took up only cases with surgical aphakia. It was done for 3 months. We recruited 112 eyes, and about 38 eyes were lost to follow-up. We had 73 eyes standing after 6 months. So they were in 3 groups as follows. Now, these are all published procedures, so for brevity and I'll have to present it in 6 minutes, so I'm not going into the surgical technique, but suffice to say that CM-T-Flex IOL was done with the handshake technique, and the T-shaped haptics rested under scleral flaps at 3 and 9 o'clock meridian. So coming to the results, what do the numbers say? I'm not going to complicate things too much. I'm not going too much into p-values and refractive details, but let me just say there were no difference in the 3 groups with respect to age, gender, laterality, IOL power, or axial length. But we see that the iris claw lens patients, there was a shorter gap between the primary surgery and placement of the secondary IOL, and the lenticular remnants and the need for a full PP was obviously lesser in the iris claw group. When it comes to duration of surgery, we see that patients who underwent iris claw lens surgery had a shorter duration, and 1 person with a scleral fixated lens needed a re-surgery within a month to refix the haptic. The iris claw lens patients were shown to have a hyperopic refractive shift that was significantly different. It is seen here, the refractive error shows a hyperopic shift in this box whisker plot, whereas coming to best corrected visual acuity, all 3 lenses were same at 1 month and at 6 months. Moving on to the important part of undesirable effects. We see that there was no significant difference between the 3 groups with respect to parameters like corneal edema or IOL dislocation. But when it comes to AC reaction, having an irregular pupil or having an IOL tilt, the iris claw lenses, the group had a little more significant change. Whereas a couple of people with the standard scleral fixated lens had haptic exposure at 6 months. That was significantly more. So that was the numbers, that's what we saw. Moving on to the discussion, our study has actually brought out some things that we already know. For example, the iris claw lens surgery takes lesser time, the visual outcomes are comparable, and that iris claw probably you will anticipate a little more inflammation because the iris is disturbed. But what does our study add? What does our study add to the literature? We found that the CM-T-Flex lens is comparable to both the standard options as far as the eventual visual acuity is concerned. And more importantly, I keep stressing that the complication profile is also not very, very high, or in fact, it's much better than the SFIOL lens and the iris claw lenses. Of course, our study was not without limitations. We had a lot of limitations. It was a small sample size. And as I mentioned, we couldn't randomize the study because, there are certain cases with absent capsular support where the primary surgeon, the surgeon who's doing the cataract surgery, feels he can manage it. So we couldn't, bring the patient out and take him back inside. It was a short follow-up period. Obviously, it was before COVID, and we lost a lot of patients to follow up after that. Nevertheless, there are certain valuable conclusions that this pilot study could tell us. In CMT flex lens, in comparison with the SFIOL and iris claw lens, we found that the refractive outcomes are better than the iris claw lens, and visual outcomes are definitely comparable to the standard options of the 3-piece SFIOL and the iris claw lens. And when we talk about fixing a lens to the sclera, most importantly, we need to know about the haptic exposure, and the CMT flex lens haptic exposure is similar or better than the SFIOL. Finally, when we talk about inflammation, pupil distortion, and other major side effects in the posterior segment, we see that the CMT flex lens is comparable to the SFIOL and really better than the iris claw lens. Beautiful. Thank you for patient audience.
On the dot.
On the dot you finished, huh? Good.
Thanks, doctor. Doctor, was there any case where this lens could not be implanted?
Initially, sir, when we were out of the study, initially even before the study was planned, when the surgeons were getting used to the lens, what happens was we used to tear the lens. We used to pull the lens a little more hard. But then we realized there's no point in pulling. We just have to push with the injector. The other one comes out just like that.
What's the follow-up period?
This particular study, we have a follow-up period for 6 months, ma'am. All the eyes completed a 6-month follow-up.
It's done in primary setting or secondary?
CMT flex is always in the secondary setting.
Oh.
It comes in one single size or two sizes, doctor?
It comes in a single size.
Single size.
It's a major disadvantage, no? Secondary setting. It's a major disadvantage.
Sorry, madam.
A second surgery is a major disadvantage.
Yes, exactly. Yes,
I mean, that itself is a big deal because you can do SFIOL or other one on the table.
Primary on table.